Yes, as Dr. Radhika has rightly pointed, this is possibly the most challenging scenario we face as corneal surgeons. So this will be a video-based talk in which I will be giving the voiceover. So this is the first case which I operated on the 17th, about a week ago. So this gentleman presented to the OPD with this picture, and the history was trauma with a vegetable matter, but he was not very sure about it. About a week before he presented like this. So I'll just go on to the video. So this video starts when the 360-degree peritomy has been done and some amount of hemostasis has been achieved. So here the key is properly measuring the diameter to be trephined. And here the diameter of the host trephination was 12 millimeters, and the 1 millimeter oversize of the donor was taken. That was a 13 millimeter graft. The key is not to do a full thickness punch right at the outset, and you can zoom out a bit when you're initially trephining to get a broader field of view. And once you have the mark in situ, you can just do what I am doing now with a keratome, just deepen the groove gradually. But sometimes it's difficult because of the necrotic tissue everywhere. The instrument keeps on slipping, both the tooth forceps and the side port in my left hand. So you have to keep on changing hands left, right, so that you get a more better control on the depth of the groove. Once this is done, you can just keep on, just try and make an adequate groove about 360 degrees. It's difficult to assess, especially with the blood vessels which get nicked and the blood keeps on oozing. But the key is here not to go too deep, not to try and puncture the iris or the deeper tissues inside. You can always make a small stab incision, insert some viscoelastic, and then enter the anterior chamber, inject viscoelastic, and then proceed with the. Here I've made the entry now. The key is to keep the plane parallel to the iris so that you don't dip the side port into the eye while you are making the stab incision. Here before that I've just injected a small amount of pilocarpine. So try and get the pupil down, doesn't work always. So here again, viscoelastic is your greatest friend in these type of cases. So be generous with viscoelastic. It can be anything you have in your hand. It can be dispersive, cohesive. Doesn't matter if you don't have a very particular brand or type of viscoelastic. Just be generous. You ask your assistant to keep on putting viscoelastic at each and every step so that the tissues are pushed down. Again, while cutting this with the scissors, the key is again to keep the blades parallel to the iris plane and not dip them inside, so that you don't inadvertently cut the iris tissue or injure the lens. Try and salvage the lens as much as possible in these cases, because a lens expulsion or an inadvertent capsular rupture changes the prognosis and makes the case more complex. Now here I am using the closed blades of a McPherson forceps to try and get separate disc. Again, the key is not to be very aggressive because these exudates are very tightly adherent to the. So there has been an inadvertent iris hole here, but it can work as a PI. It depends on how you look at the glass, half empty or half full. So once you get off the membrane, don't be very aggressive again, and don't try to clear this below the iris plane. Sometimes you may end up nicking the anterior capsule, and then you have to go ahead with a cataract extraction. So just again, generous amounts of viscoelastic, try and separate the membranes, the exudates from the iris surface as much as possible. If you see where my mouse pointer is, there is still this amount of this ledge, so to say, which is still infected. So try and remove it, like with a blunt dissection or with the scissor, as much as possible. So this is what I'm precisely trying to grasp, but be careful that you don't end up grasping the iris at this point. Again, you see this defect has cropped up, but sometimes you have to sacrifice some bit of tissue so that in the post-operative period you don't see the infection recurring from precisely where you ignored or inadvertently left off this ledge of infected material. So keep on trimming it slowly. Again, keep the blades parallel to the iris tissue. These are all desperate cases. So this is the at the end of the surgery. So I'll move on to the next case. Before that, this was the follow-up just 5 days ago. This is post-op day operative 5. On the scraping on the table, the gram stain showed the presence of both gram-positive cocci and fungal hyphae. But the culture on post-op day 5 didn't show any bacteria, it just showed fusarium. So the AC is still formed, but you can see a lot of reaction in some exudates in the anterior chamber. So the key is to continue the aggressive topical and systemic antifungals as well, and hope that it turns out to be fine. So the case 2 was referred to me a few days back, again coincidentally operated on the same day as the previous case. The patient had undergone a phacoemulsification with IOL. There was a rent on the table. There was some cortical drop. A multi-piece IOL was placed by the operating the primary surgeon. The patient was a known diabetic, so that's a risk factor right there. At day 6 post-op, the patient came for a checkup with diminution of vision. The surgeon noted a corneal melt. Ultrasonography revealed exudates in the vitreous and choroidals. The retinal surgeon at the peripheral branch did a AC wash, and intravitreal antibiotics were given on the same day and referred to the main branch. We did a repeat sonography, which revealed a worsening of the exudates and kissing choroidals as well. And this was the anterior segment photograph. So you can see the tunnel has melted here. It was a temporal section phacoemulsification, clear corneal. So the 2 sutures have given way, and 1 suture at the bottom side port is also given way with a total corneal abscess. So this is the video. Again, as you can see, the iris is prolapsed from the tension. So the peritomy is done. Reduce the magnification, tilt and place the trephine, which is pre-marked with gentian violet. And again, the same principle, do not go for a full thickness trephine because the iris has already given way. Just make sure with gentle firm pressure, you have an adequate marking so that you know where to deepen the groove. Again, then you increase the magnification and go ahead with the grooving. So I'll just skip this part because it's similar to the previous surgery. Here again, the picture changes when you start refining the, when you enter the cornea. Yeah, so this is, so as you can see, the multi-piece IOL, the 3-piece IOL that has popped out of the bag, and the bag, there is no bag, so to speak. It has all been replaced by dense vitreous abscess. So the key here is not to tease the structures below the iris plane. Leave it for the vitreoretinal's colleague to deal with. Do not try to pull or cut or trim the exudates. Just remove the IOL. This I sent it for culture separately, and obviously the scrapings were also done, which revealed a gram-positive cocci on the gram stain. So we started treatment as per that and waited for the culture. Here I'm removing the IOL, just again loads of viscoelastic so that the IOL comes out smoothly. Sutures are done. At the end, we pushed vancomycin and ceftazidime into the anterior chamber and formed it to the best of my ability. Then the vitreoretinal surgeon took over. So this, if you see this photograph, this is immediately post-op day 1 morning. So you can see the AC is formed, but there's a lot of copious discharge, and the patient didn't clean it properly. So this photograph is just before the initiation of the vitrectomy by the vitreoretinal surgeon. This photo is at the conclusion of the surgery. The vitreoretinal surgeon had to put 2-3 sutures because of the choroidals. The AC was not forming. There was a lot of leak. Some of the earlier sutures which I gave had become loose, so all of them were replaced. So this was at the conclusion of the surgery. The microbiology revealed 2 organisms. One was Staph aureus in the host cornea, in the IOL, and in the vitreous biopsy. And the Acinetobacter, that came from the host, but it was all sensitive. So we are hoping that at least the eye survives, if not a visual outcome in the end.